I'd like to tell you about DiGeorge syndrome. It is a congenital defect, failure of the region of the throat to develop properly. DiGeorge syndrome results from a microdeletion in the autosome or the autochromosome number 22 in the long arm, that's the Q arm, at position 11. And DiGeorge syndrome occurs due to the absence or improper development of the thymus and parathyroid. Basically, it's congenital defects, like I said, of the head, neck, and heart. And when we stop and think about the thymus, we know that this is the lymphatic organ where T cells are going to mature. So children with DiGeorge syndrome, they make T cells. They have pre-T cells, but they lack functional T cells, and therefore they're susceptible to persistent viral, fungal, and protozoan infections. Common childhood infections such as childpox. Oh my gosh, it's been a long day. Chickenpox, measles, or mumps can be fatal in these children. Even vaccinations using weakened or attenuated microbes can cause serious illness. The treatment for this disorder involves the transplant of normal thymus tissue, which they are unable to reject due to their lack of T cells, lack of mature T cells, I should say. So we transplant thymic tissue to help with the maturation of their T cells. I think that's just genius. Now, they will also be parathyroid hormone deficient if the parathyroid gland did not develop. And this means there's going to be a problem with hypocalcemia. That means too little calcium in the blood. Now, I'll remind you from physiology, calcium helps stabilize sodium voltage gated channels. That makes them less likely to open, and that means less likely for an action potential. So when someone has hypocalcemia, these sodium voltage gated channels are not well tempered. They are more fickle. They're more easily opened. And that means that the person is going to be more likely to have their sodium voltage gated channels on skeletal muscle firing an action potential, and that will lead to muscle contraction. So you yourself might have had this experience where you've had a deficiency in calcium and you wake up with muscle cramps in the middle of the night. Again, your lack of calcium, you would think you would have reduced muscle contraction because calcium is required for contraction, but in actuality, the hypocalcemia, the reduced calcium in the blood, destabilize sodium voltage gated channels, which makes an action potential more likely to happen, and then the calcium from the sarcoplasmic reticulum is going to be released. And this is the reason why infants with DiGeorge syndrome, within 24 hours of birth, they will present with tetany. They will have increased muscle tone. So in the older child or even adult, we can look for the trousseau sign. This is basically where the fingers and wrist are in a hyperflexed state. And this can occur if you're just inflating a blood pressure cuff above systolic pressure. You'll see their hands go into this classic presentation shown here in Part B. The Shavatsky, sorry, I mispronounced that one again too. The Shavatsky sign is a sign where if you simply push on a light tap over the facial nerve comes out from your ear. So basically where your parotid gland is, that's where your facial nerve, cranial nerve 7, branches into its 5 divisions. So if you rub the area right where the parotid gland is, going back towards the ear, you're going to stimulate the facial nerve. And the facial nerve, of course, if stimulated, is going to release neurotransmitter onto the skeletal muscle, and this is going to lead to the skeletal muscle being more likely to have an action potential. And the person's going to present with this contraction of the facial muscles as a response to this light tap. I mean, a light tap shouldn't make your face start to twitch like that, but again, it's the lack of calcium, the lack of stabilization for the sodium voltage gated channels, which makes this sign so easy to provoke. Pretty cool stuff, I think. What about when a person has T and B cell immunodeficiencies, like in severe combined immunodeficiency, or SCID, or SCID as it's called? Well, children with this disorder are unable to mount any type of specific immune response. Infants born with SCID develop oral yeast infections from Candida, pneumonia, sepsis, and systemic viral infections within days of birth. The most famous child, of course, with SCID was David Vedder, who lived in a sterile environment, which earned him the nickname of being the Bubble Boy, and there was a TV movie done about him. I'm sure probably you've seen it. I believe John Travolta, if I remember correctly, played that character. When David was 12 years old, he received a bone marrow transplant from his sister. Unfortunately, like 90% of the population, his sister's cells carried the oncogenic Epstein-Barr virus, or the EBV virus, and David died a short time later from metastatic cancer. Today, children with SCID receive fetal liver and stem cell transplants that have been carefully screened. An alternative treatment involving gene therapy to replace the defective genes is currently being developed. So again, the infants are going to initially present with failure to thrive, the opportunistic infections, the candidiasis or the oral yeast infection, the diarrhea, etc. Survival after 1 year is very, very rare, and detection is critical. We need to know who they are before the first infection, because then we can put them in a sterile environment and protect them. The X-linked variety is the most common. However, there is some SCIDs, people with SCID, due to an adenosine deaminase deficiency. This also can be seen. The absence of the ADA enzyme leads to the accumulation of toxic metabolites that kill dividing and resting T cells. Let's see, I think that's all I want to say about that. Now we're on to disorders of phagocytosis, and these are pretty cool. I'm going to focus mostly just on one. Chronic granulomatosis or chronic granulomatosis disease is a problem with phagocytic cells and their respiratory burst. Well, first, what is a respiratory burst? The respiratory burst is basically the ability of phagocytic cells to produce free radicals, reactive oxygen species. And these reactive oxygen species, like superoxide anion and hydrogen peroxide, are used in an intracellular environment to kill the ingested microorganisms. So the microorganisms are basically killed with these free radical species, reactive oxygen species, that punch holes in their cellular membranes and then cause them to rupture. Well, in chronic granulomatosis disease, it's a problem with the NADPH oxidase enzyme. So these cells cannot produce those free radicals or reactive oxygen species. And so these phagocytic cells can still engulf the microorganism. They can still phagocytose the microbe, and the microbe stays viable inside them, and they just can't kill them off. So how do we diagnose this disorder? Well, we look for the person's inability to reduce a yellow dye to a blue compound. And this is called nitroblue tetrazolium, or NBT as it's called here. And if you look at the bottom, we've got a control positive NBT phagocytic cells. These are neutrophils. If you look on the bottom right picture, the control, you see that they take that yellow dye and they reduce it into a blue dye. And the person with chronic granulomatosis disease, they cannot reduce it, and so the cells remain a lighter stain. So obviously people with CGD are going to be subject to chronic and acute infections of the skin, liver, lung, and other soft tissues despite aggressive antibiotic therapy. They might present with severe acne, and painful inflammation of the nares is very common. Again, they're going to be susceptible to different bacteria. Now it's time to move on to our hypersensitivities. A hypersensitivity reaction is an overreaction to an antigen that is not harmful or an exaggerated immune response that cannot be turned off. Hypersensitivities are divided into 4 categories. 1, immediate, 2, cytotoxic, 3, immune complex, and 4, delayed allergies. They're also known as type 1, 2, 3, and 4. Again, type 1, immediate hypersensitivity. Symptoms and mechanisms involved include the IgE-mediated response, mast cells, basophils, and allergic mediators. And the examples of these would be anaphylaxis, allergies such as hay fever, asthma, peanut allergies even, etc. The type 2 or antibody mediated is going to involve your IgGs and IgM antibodies. They act upon cells with the complement system and cause cell lysis. And this includes some autoimmune diseases. Perfect example would be myasthenia gravis and blood group incompatibility. Type 3, this is the immune complex mediated. This is an antibody-mediated inflammation, circulating IgG complexes deposited in the basement membranes of target organs. And this is going to induce, again, the complement response. And we're going to see this in systemic lupus erythematosus and rheumatoid arthritis, and even in something called serum sickness. In type 4 or T-cell mediated, this is going to be delayed hypersensitivity, and it's going to involve cytotoxic reactions in tissues. And the perfect example of this is like latex allergies. Latex allergies can be type 1 or type 4, and this is going to result in contact dermatitis. So let's talk about type 1 disorders first. Type 1 hypersensitivities are called immediate allergies. They are triggered by allergens, which are foreign molecules such as foods, dust, mold, pet hair, and saliva. Insect toxins, dust mites, pollen, latex, like I said, can be considered a type 1. And these are going to cause an allergic response. These responses are mediated by B cells that produce IgE antibodies, which bind to the surface of basophils and mast cells. Each basophil and mast cell carries about 30,000 to 100,000 receptors that can bind to 10,000 to 40,000 IgE antibodies. When an allergen binds to the IgE antibodies on the surface of basophils or mast cells, it triggers the release or degranulation of chemicals such as histamine and the production of leukotrienes and prostaglandins. Histamine, leukotrienes, and prostaglandins cause localized urticaria, which is a fancy name for hives, hay fever, asthma, atopic dermatitis, or it can lead to systemic effects like anaphylaxis. It depends on the amount of the allergen and the site at which these chemicals are released. Hay fever or allergic rhinitis is localized to the upper respiratory tract and is characterized by watery eyes, a runny nose, itchy throat, and sneezing. Asthma is a chronic hypersensitivity condition that affects the lungs and lower respiratory tract. Asthma leads to bronchoconstriction, which is the narrowing of air passageways, making it difficult to breathe. Urticaria, or hives, are round, raised, itchy skin lesions that often form as a result of skin or food allergies. Food allergies can lead to abdominal cramps, vomiting, and diarrhea due to the contraction of smooth muscles. So again, these hypersensitivity disorders can be from anywhere from annoying, from the urticaria and the allergic rhinitis, to severely debilitating, like in the asthma, to life-threatening, as in anaphylaxis. And I'd like to explain to you what happens with anaphylaxis in the next few slides. Basically what we're seeing is the involvement of helper T cells, the type 2 helper T cells. What they do is release cytokines, and they cause B cells to mature into the IgE producing plasma cells. And these IgEs are going to bind to allergens, and then these IgE allergen complexes are going to dock onto mast cells and basophils. And both the mast cells and basophils are going to release copious amounts of histamine and heparin. And this is going to promote more vascular flow, vasodilation, but in other places, like in the bronchial smooth muscle, this is going to lead to bronchial constriction. So this is going to be a problem with people with asthma allergies. And we're also going to see that in the case of anaphylaxis, this can cause profound drops in blood pressure. Let me explain. So, type 1. Let's now focus on this. Let's focus on, let's say, a peanut allergy, okay, in this picture. Remember that the immune system must have homeostasis. We don't want too much or too little reactivity to antigens, because that's not going to be a healthy balance. So let's just focus on these hypersensitivities or allergies. Pretend that we're looking inside a small child who has just ingested some peanuts for the first time. Unbeknownst to the child, the peanuts are going to create a peanut allergy. Let's go step by step and appreciate how the peanut allergy will develop. The child has eaten a peanut, and the proteins of the peanut are antigenic to this particular child. That means the child's macrophage has docked to the peanut antigens, internalized them, and broke them down. Some of the peanut antigens are now presented in the cell membrane of this antigen-presenting cell. You'll notice that here in the top left picture, where you see the antigenic peptide from the peanut presented in the macrophage. This macrophage, with its antigen presented, can now bind to a helper T cell through a major histocompatibility 2 protein. The activated T helper cell now releases many cytokines. These cytokines can now activate cytotoxic T cells. Additionally, the helper T cell can activate a B cell. Shown here in the top right-hand picture, the B cell has already bound the peanut antigen on its own and is also being stimulated by an activated T helper cell. Both of these routes can lead to a B cell that will rapidly replicate and divide to create clones. Some of these clones will remain as memory cells. Other clones will become mature B cells called plasma cells. These plasma cells in this example are secreting IgE antibodies. IgE antibodies bind to receptors on the mast cells. This is shown here with a red IgE antibody embedded in the receptor of a mast cell. Now we have mast cells with the IgE antibodies embedded in their cell membrane. This same process could occur in a basophil as well, I want to remind you. Now, if the child eats another peanut in the future, the peanut antigen can bind to the IgE complexes within the cell membrane of a mast cell or basophil. When the antigen binds, this stimulates the mast cells or basophils to release huge amounts of histamine granules, and this will lead to a severe allergic reaction, a lot of vasodilation, a lot of capillary permeability. If enough granules are released, so much vasodilation and increased capillary permeability can occur that this can lead to anaphylactic shock, where the child's blood pressure drastically drops. The question is, why does the child's blood pressure drop? Well, perhaps we should revisit those Starling forces again. If you look at the red line that's dashed across your screen here, it is a line representing capillary hydrostatic pressure, capillary osmotic pressure. This is an osmotic pressure created from the albumin. If you look at the green line that slopes downward, that represents capillary hydrostatic pressure or blood pressure. If the capillary blood pressure is greater than the osmotic pressure, then there will be a net movement of fluid out of the capillary. If the capillary osmotic pressure from the albumin is higher than the capillary blood pressure, then there is going to be net movement of fluid into the capillary. And the overall amount of filtered fluid is dependent on, if you look at the bottom of the screen, the KF. KF stands for the capillary permeability. And in parentheses, you're seeing all these Starling forces. You're seeing the little pi sign represents osmotic pressure from the capillary and interstitial space, and the capital P represents the hydrostatic pressure from the capillary bed or the interstitial fluid. Basically, we take all of these forces together to determine how much fluid will be leaked into the interstitial space. When we're considering these hypersensitivity type 1s, we can see how they can quickly become life-threatening in the case of our peanut allergy. We get this excessive allergic response. We get the IgEs binding to the peanut antigen, docked to the mast cells and basophils. There's massive granulation, which means they release their histamine and heparin. This histamine is going to change the permeability factor, that KF I just showed you. This means increased gaps in between the endothelial cells, and heparin is going to ensure that the blood does not coagulate. So it's going to stay in a fluid state. So we have extreme venous dilation, arterial dilation, and capillary permeability has been increased. All of this means that you can have increased fluid loss into the interstitial spaces. And that means blood volume and blood pressure will drop drastically, both from leaked fluid but also the extreme venous and arterial dilation. So this is a very severe problem, and the person needs to be given epinephrine so that the epinephrine can stimulate the alpha-1 receptors and restore the blood vessel constriction, restore the pressure on the blood inside, and restore perfusion. It's now time to move on to type 2 hypersensitivities. Type 2 hypersensitivities are called cytotoxic. They're caused by antibodies from IgM and IgG that target host cells for destruction by complement-assisted lysis. Examples include blood transfusions, hemolytic disease of the newborn caused by Rh blood factor, and thrombocytopenia. Red blood cells have blood group antigens on their surface that determine a person's ABO blood type. Of course, you learned this in physiology, but just to remind you, people with type A blood have the type A antigen, which is N-acetylgalactosamine. People with type B blood have the type B antigen, which is the sugar galactose. And of course, people who are AB blood have both of those antigens. And the blood type O, they lack the N-terminal sugar, so they don't have that antigen. If blood is transfused to an individual with a different blood type, the donor's red blood cell antigens will trigger the recipient to produce antibodies against the foreign blood antigens. These antibodies will bind to and agglutinate the donor cells and target them for destruction by complement-assisted lysis. This causes a life-threatening transfusion reaction, which can lead to systemic shock and kidney failure due to the blockage of the kidney glomeruli, which we discussed in our previous lecture. Red blood cell destruction also causes fever, anemia, and jaundice. To treat a patient that has undergone a type 2 transfusion reaction, drugs that remove hemoglobin from the blood must be administered, and another transfusion with blood cells of the correct type this time must be started right away. Another antigen found on the surface of red blood cells is the Rh factor. It was first studied in rhesus monkeys, and about 85 to 90% of us have this Rh factor. If you have it, we say you're positive. If you don't have it, then we say you're negative. Now, initial sensitization to the Rh antigen occurs when fetal cells leak into the mother's circulation late in pregnancy, or during delivery when the placenta tears away. This stimulates the mother to produce anti-Rh antibodies, or IgGs, against the Rh factor. If the Rh negative woman becomes pregnant with a subsequent Rh positive fetus, the mother will produce antibodies against those Rh antigens on the fetal red blood cells. These antibodies cross the placenta, they will destroy the fetal red blood cells, and hemoglobin will be released, causing hemolytic disease of the newborn, also known as erythroblastosis fetalis. As hemoglobin breaks down, it will form a yellowish-brown substance called bilirubin. As bilirubin levels increase due to the destruction of fetal red blood cells, the baby will take on a yellow or jaundice appearance, and the accumulation of bilirubin can lead to kernicterus. So the ABO incompatibility due to a bad blood transfusion, or Rh factor incompatibility in the case of the mom and fetus, are perfect examples of the complement antibody-mediated cell destruction, or cytotoxic. Another type of type 2 hypersensitivity that I'll discuss later is an antibody-mediated cellular dysfunction. In this case, we're going to explore Graves' disease. Graves' disease is, of course, an antibody that is an autoantibody that is directed against the thyroid-stimulating hormone receptor on the thyroid and leads to hyperthyroidism. I'll talk about that in a little bit. And another example is myasthenia gravis, in which case autoantibodies are attacking the nicotinic acetylcholine receptors on the neuromuscular end plates, and this is going to block the action of acetylcholine and lead to decreased motor tone. Type 3 hypersensitivities are caused by, in the immune complex type, are caused by the formation of antibody-antigen complexes that accumulate in tissues and organs and target them for destruction. Examples include the Arthus reaction, serum sickness, farmer's lung, rheumatoid arthritis, systemic lupus erythematosus, and glomerulonephritis. When an individual is exposed to large amounts of an antigen during illness, the body responds by producing large quantities of neutralizing IgM and IgG antibodies. As these antibodies bind to their target antigens, they form immune complexes that are deposited in the walls of the blood vessels, the kidneys, lungs, joints, and skin. These immune complexes cause mast cells to degranulate, releasing histamine. Neutrophils migrate to the site of the immune complex and release enzymes that damage the host cells and tissues. In the case of glomerulonephritis, this occurs when immune complexes are deposited in the glomeruli. This is the blood filtering region of the kidneys. Damage to the vessels can result in kidney failure, as the glomeruli lose their ability to filter waste from the body. That's because, again, kidney failure is the glomeruli are losing their ability to filter waste. If left untreated, the Streptococcus pyogenes infections can lead to type 3 hypersensitivity reactions in children, causing fluid retention, high blood pressure, and kidney failure. In the case of the Arthus reaction, it's a term used by pathologists and immunologists to describe localized tissue necrosis. In the laboratory, an Arthus reaction can be produced by injecting an antigen preparation into the skin of an immune animal with high levels of circulating antibody, and within 4 to 10 hours, this raised red lesion is going to appear at the site of the injection. And then an ulcer often forms in the center. And it's thought that the antigen diffuses into the blood vessels, and that's where it's going to come into contact with the complement activating IgG or IgM immunoglobulins. And this is going to lead to blood-borne immune complexes that are going to be deposited in tissues, and the complement activation at the site of the immune complex deposition leads to the attraction of leukocytes that are responsible for the vessel and tissue injury. Type 4 hypersensitivities, or delayed, are caused by a T-cell mediated inflammatory reaction that takes 24 to 72 hours to occur. Type 4 hypersensitivities result when T-cells respond to antigens displayed on self-tissues or transplanted foreign tissues. Examples include contact dermatitis, transplant rejections, and the tuberculin response. The most common delayed type 4 reaction is contact dermatitis. Contact dermatitis is caused by exposure to chemicals in poison ivy or poison oak that bind to and modify skin cells. The chemicals present to T helper 1 cells by the chemicals presented to T helper 1 cells by dendritic cells in the skin. These helper T cells, subtype 1, recruit and activate macrophages and CD8 toxic T cells. This leads to inflammation and cytotoxic T cell mediated destruction of the chemically modified cells. Another example of type 4 delayed hypersensitivity is the tuberculin response, or TB skin test. For this test, a tuberculin extract, PPD, from the bacterium Mycobacterium tuberculosis is injected under your skin. When tuberculin is injected into the skin of a person who has never been infected or vaccinated, no response occurs. However, when tuberculin is injected into someone who has been infected with Mycobacterium tuberculosis, a red hard swelling of 10 millimeters or greater is caused by the recruitment of macrophages and T cells at the injection site. The inflammation at the injection site reaches its greatest intensity 24 to 72 hours after injection of the tuberculin extract. Okay, so what should you have learned from the hypersensitivities? Hypersensitivities are divided into 4 categories, either numbered 1 through 4, or in the following way. Type 1 is called immediate. Type 2 is called cytotoxic. Type 3 is immune complex. And type 4 is involving delayed allergies. Type 1 hypersensitivities, again, immediate allergies, and they are mediated by B cells and IgEs. This is going to involve a lot of release of histamine, leukotrienes, and prostaglandins. It leads to urticaria, hay fever, asthma, or systemic effects like anaphylaxis, so your peanut allergies, asthma. Type 2, cytotoxic. This is a problem with IgM and IgGs, and this is going to target cells for destruction. Classic examples would be the hemolytic disease of the newborn and incompatible blood transfusions. Type 3 hypersensitivities, this is an immune complex caused by antibody-antigen complexes that accumulate in tissues and organs and then targets them for destructions. And the classic example for that would be the glomerular nephritis that I told you about. And also, we're going to see this again in, I told you about it again in the Arthus reaction. Type 4 hypersensitivities are called delayed because it takes about 24 to 72 hours to occur. Classic example would be contact dermatitis, say from latex. Allergies, which are also type 1, by the way, or can be type 1, poison oak, poison ivy, and the tuberculin response.